for the wonderful presentation. Yeah, right. Thank you. Rima, would you like to bring closure to our?
Closure to the exercise. We are behind time, and I know that we have another activity, so I don't want to stand between people and their taxis. But if you recall, and for people who came in late, you were charged to begin thinking about the deconstruction exercise. And in that beginning process, the exercise you were considering was the activity of taking medicine as prescribed. And I asked you if you could, during the course of the day, break that down into tasks and identify those tasks and have a list of those. And then I ask you to star or highlight those tasks that had a numeracy component. So let me, as a way of just making you think about your work for a moment or two, I'm curious as to whether or not you included math concepts when there were words like risk, normal, range, in just words only and not numbers? Did you include tools? Did you include cost and coverage? Did you include visual displays? Because all of those really do involve numeracy skills and math skills. So let's just look at the findings. So I'm curious first as to how many tasks people broke things down into, if people did indeed engage in the activity. How many of you had 10 or fewer tasks on your list? 20 or fewer? How many of you had over 21 tasks on your list? Fantastic. Because as I had mentioned, I was working with a group of people who identified 30, and I was told you can have a lot more than 30 individual tasks if you really do it with a great deal of care. And so that task breakdown was very important. Now, I'm curious about the proportion of those tasks that you identified as having some kind of numeric component. Would you say that a quarter of those tasks involved numeracy? For those of you who did the exercise? A half? More than half? If someone would just volunteer, you were shaking your head, yes, Wilma?
What I have to do is, since I'm on this automated CVS thing, but all they do is tell you they have a prescription ready. I don't know which one they have ready. They just have something ready. So then I have to look at, my meds and then think, okay, well, I have plenty, because then I count them out to see, am I getting close to I have like 3 weeks left. Why am I getting caught? So anyway, then, what I'll do is I will go ahead and visit the pharmacist and give them my information, and they'll provide it. And, then they say to me, you just sign here. And I'm like, wait, I have questions. My sister's a pharmacist, so I've been trained well. And so,
I asked,
Yeah.
I say, what is it
Yeah.
you're asking me to sign?
Yeah.
No, it's
Yeah.
not that I just got my medication.
and so one of the tests that I was thinking about in your last question was, am I going to have enough meds in the event that the week gets crazy and I can't get there this week? So I have to count out that I'm going to have enough in the event that I'm not going to be able to get there. So that gives me that wiggle room. So that's one of the ways that I have to strategize how to not be non-compliant with meds that are not optional.
Terrific. Is there anyone who had a long list of mathematical tasks and is willing just to very quickly read through that list? Yes?
Yeah, I hope this fits your criteria here. Okay, long story short, I have some autoimmune things. So a few years ago, I thought it was a big deal. Sorry, oh, okay.
But do keep the waiting taxi in mind.
Yes, okay. Can you hear me? Okay, yeah, I was going to say a long time ago, I thought taking thyroid medication was the end of the world, and then I got diagnosed with a few diseases and so forth, so I have to take about 21 pills and vitamins over the course of a day at 7 different times, and sometimes I feel miserable, so it doesn't, not all the time, but I'm sure it affects things. One point I'd like to say before I say the rattled through the other things is that as far as numeracy, I've had a couple times where I was given a new medication that was heavy duty. And I'm a PhD, so I'm thinking, okay, I'm not just going to belt this down. I want to read the label. But at those times, I was feeling bad enough. I didn't feel up to reading the label, but I was afraid to take the medication. So I think there are certainly implications of that kind of thing. It was too much, the FDA label, so no offense to any FDA people in the room. But let's see, well, just straightening out the MedMinder, having to remind from the beginning when I get the prescription with the doctor or they discuss it, I have to remind them, make sure you put dispensed as written, blah, blah, blah. Let's see. I have to keep track of things like if it's a generic, have they changed the generic? Because I've had some bad reactions that way.
Focusing on numeracy,
I'm sorry?
the numeracy highlight.
Yeah, I'm sorry. I'm not doing very well with that. Let's let someone else speak to this.
Yes.
It's,
Patrick.
I looked at, I kind of misunderstood your assignment, so that's not remarkable, but I talk about dealing with.
Because I'm not clear.
No, I'm a little obtuse sometimes. I was talking about dealing with a periodontal condition, and then the numbers involved in dealing with gum disease is unbelievable. You have, 3.5 to 5.5 millimeters, code 0 through 4, 3 bundle, 3.443. What's that mean? And then also I have to have my teeth cleaned 4 times a year instead of once a year. Also, the costs, which my copay gets my head spinning. Then they got me taking chlorhexidine, Paradix 3 times a day, half hour after eating, 1/2 or 1.5 milliliters. Is that enough math for you?
That's enough math.
Okay.
I was indirectly criticized for using a medical and not a prevention example, but I need to tell you that I spent hours on the CDC website, and there are absolutely thousands of examples of high math load on information that's given out to the public about taking action that is preventive action, if you include things in environmental health, for example. So the math overload is just so profound, what we are asking people to address and to deal with. And I think it's extremely exciting that we are taking action on this as a committee, as a community. And I think that this can begin to open up a new doorway that we have to go through in order to make efficacious change. But the burden can be overwhelming. So thank you for the time.
Thank you. What we wanted to do, and we have 15 minutes left to do this, so I don't know if we'll get all the way around, but it would be really nice if we did, for everybody to kind of give 2 or 3, briefly, 2 or 3 key points that they picked up from today. And briefly, and since I've always been going around this way, we'll start with Margaret.
Thank you. I wanted to ask a question of Rima, though. It's sort of been bothering me. You mentioned at one point your students, or I think the postdocs, could not express or explain what risk was to a family member. And I was curious how you answered that afterwards. Did you give them an answer how to explain what risk was?
No. I gave them a wealth of metaphors that many people have used to explain risk, and many of those metaphors are applicable to many different people, but no one metaphor was applicable to all. So the sports metaphor of finding a $100 bill taped underneath your seat in Fenway Park. So the metaphor that had to do with shopping, there wasn't a metaphor that fit all cases. So I use that as an example, and I use that as a profound note to think about, because they're all taking biostatistics and epidemiology, to think about how they would translate their new knowledge in everyday words in the marketplace to other people, that was the challenge for the year. So no, I did not offer an answer because I don't think one exists yet.
Tremendous, and that was just a preamble to what I wanted to say. And I think today, we learned that numeracy affects everyone, everything, all of us. And I think I became so energized and aware that in everything I do, and I need to be even more aware because I do a lot of consumer work that I need to be thinking of it even more. And the thing that hit me is the presentations on journalism, how we can partner with journalists more at every level, with the healthcare providers, with consumers, and from industry. We provide press releases for a lot of the things that we do, but we don't think of putting it into comprehensive, using those numbers in a more comprehensive fashion. So I think now that's a great lesson that I've learned from today, that we need to not just put 16.2% versus 1.3%. We need to make it a little more relevant. So I learned a lot from that, and I think the other thing that with Andrea's presentation, that we've got a lot of things that we need to do now and urgently, but we also, the word has to get out somehow, probably not from us, but that education is the long-term solution, and that can't be forgotten. And then I was a little surprised about that we had to bring up the question of ethics, because healthcare providers, that should be ingrained in us, that we present information on ethical, complete, understandable way. It's not, but it should be. And I don't think that we, as healthcare providers, we should be using our opinions to influence patients. We should be presenting the facts. But I think, George, you made it very clear that doesn't always happen.
Lindsay?
In the interest of time, I'll be very brief. I didn't hear much about oral health today, so I was really happy when Patrick gave the oral health example, the pocket daps, and that's not a comfortable process either, going through around each tooth to determine periodontal status. But I'd like to think about reframing the oral cavity for those who are in the physician and medical provider community. Think of it in terms of the gateway and the entry point to the gastrointestinal system. And it's a gateway to the entire body. So I'm hoping that I can share my perspective on oral health and incorporate that more in the work that the Institute of this Roundtable does in the future. One other thing I just wanted to mention was that I heard a recurring theme among many of the speakers in terms of translating information to communicating to patients and consumers that the idea of less is more, sort of the KISS principle. That really resonated with me throughout the day. So thanks.
Steve?
Yes, thanks. I was really energized and very appreciative of all the research that's been done on numeracy and cognitive skills. I think that I'm better able to create a business case going forward within my organization, and also when I work with healthcare professionals. The challenge for me personally is, how do I move people from health literacy is reading to health literacy is math skills and cognitive processing skills? Because we've been talking about reading grade levels for a long time. But overall, I found today very, very exciting. I think that there was great participation. The information that was provided to us was just outstanding, and it came from multiple viewpoints, which I thought was really, really important. Thank you.
All right.
I too enjoyed the day thoroughly. I like hearing all of our little tidbits around the room. It reminds me literacy is both hearing and verbalizing, and so we've each heard different things today. It's a good reminder. So what I heard, I come from the patient-centered medical home world, working with people who typically are uninsured or on Medicaid, and also in integrated behavioral health and integrated oral health, and also outreach workers to get people enrolled in this new world. And what struck me, some of the things that struck me today, I like the comment I heard about health literacy being bi-directional, or being a combination of both the communicator and that person listening or reading, as opposed to somebody who is health illiterate, but perhaps it is us that are speaking poorly or communicating poorly. And that was just a good reminder for me. And then the idea of teaching providers how to communicate. As I said earlier, the thing I think about is not just providers, but the whole team of people that work around the patient. And so I'm excited to take this beyond the medical model. And then the decision support tool that we heard, I thought that was intriguing to think about how HIT could play a role, not only in communicating with the patient, but what I found in healthcare is if we can help the provider team communicate appropriately through HIT, perhaps, it will cue us to do the right things in our communication patterns. And so I'm really excited to think about that. Thanks.
Wilma?
I agree. This has been just an amazing day, and I'm very appreciative of all the speakers and the content that was presented, and for myself, making me think of things in different ways. So I thought that was great. And I'm also appreciative that you started on this side of the table, because everybody has said such amazing things. And I'm like, wow, that's right. Yeah, that's right. So anyway, so I'm gonna quote Margaret and say that, you know, there's lots of things to do now and urgently. And see, you're like, what, the fifth person out? So I'm the fifth person out. So the education regarding the math and the cognitive processing, that is so key. And I think that our youth are not educated and thinking that there's different types of math for different types of situations. You know, it's what the teacher wants versus what the grade is, and then what the reality is. So I think that's one takeaway for myself. And then if it isn't happening already, or if it hasn't or isn't happening already, I really feel that this conversation has to be part of the health benefits exchange, especially with the patient navigators, because at least for the descriptions for those positions and those communities for my current home state, there isn't a mention of numeracy, and this is a concern. This is a concern. And so that's one of the takeaways that I'll be trying to do what I can in my state to bring this message to them, that this is important not only for the navigators, but any community-based organization that's going to be working with, in concert with the health benefits exchange with the outreach component.
Cindy?
Cindy Brock, 3 points. First is a personal point, which was that it was very gratifying to hear about the consumer checkbook's use of ARC data from the medical expenditure panel survey and from the CAP surveys, that, you know, we're actually putting those data into helping people make real world decisions. And maybe lots of people in my agency already knew that those data were being used that way, but I thought that was terrific. So we talk a lot about the demand side and the skills side of the health literacy equation. And I spend a lot of time in terms of focusing on reducing demands. And my big takeaway, sort of unfortunately and perhaps a little more direly than called for, but is we really don't have very good science on reducing the cognitive load for quantitative information, and that this is not a call for more research, but rather a fallback to the universal precautions approach, and particularly thinking about Terry and colleagues' study around sort of teach back versus show me. If people sometimes are able to say, you know, how to do something, but then when you ask them to demonstrate it, they actually don't show you the right thing. And so, you know, how important it is to use those with everybody all the time, because we really don't have the answers yet of how to communicate quantitative information effectively. On the demand side, and I had this done before Wilma made her remark, but I get nervous when I hear about the poor state of, you know, math knowledge and math education and reading in schools in America, that we are going to continue what I consider a very ill-advised retreat from very important educational activities of physical activity and drama and art and music, and, you know, I could name half dozen other, that as we continue to ever focus more narrowly on math and reading. And so I would call our educational partners not to hear this as a call to, oh, we've got to, you know, drill those math concepts in more, but of really thinking about some of the more progressive education approaches of perhaps project-based learning, or some of the things that Linda was talking about of how we, you know, there's a curriculum called Everyday Math, but which I know nothing about, but she was giving everyday examples of how we use math, and those, you know, working about incorporating those things. And Lila's giving me the okay, Cindy, enough.
Terry?
Hi. Yes, today it was a great day, and it energized me once again. I have my to-do list for when I go back. But it was a reminder really for me today of really the burden that numeracy interpretation, you know, really has upon decision-making and treatment decisions. And then how that, you know, certainly I start thinking of then certain populations like end-of-life care, palliative care, and then, you know, quality of life, and then outcomes and costs, which is so important. And then at the same time, today's discussions really energized me to really think of opportunities of how we can utilize the numeracy concept to really engage patients and consumers of health care and empower them to, and I think we have lots of opportunities that, you know, we can do that if we just stay focused. So thank you.
Who?
So I also have Susan's comment. She asked me to just mention the three of them. One, that we need a good summary of the principles for good approaches to numeracy and icons. We need a concise, good summary. That the overall issue of numeracy is underestimated in importance, and we need to be very aware of that. And third, that Andrea's tool was magnificent. Those were her three comments. The ones
I'm
move
sorry,
up
what was
and to
the
the
last?
left.
The last one was?
Andrea's tool is magnificent. That's her third one, you know, move up
to
and to
go
the
up,
left
yes,
and the
yes,
right. Yeah,
right.
those were the three things she asked me to mention. And then the ones I wanted to mention, which really fall in line with what I think the folks before me have said. One really highlights what I think is an opportunity, and it grows a bit from the conversation that we had when we worked on the attributes of health literate organizations, when we put as our 10th attribute and had discussion about it, that moving forward, cost transparency is needed. And I started thinking today that just as much of literacy is beyond words, cost is beyond numbers, and involves a culture shift and a new language and new ways of approaching something that's very uncomfortable, and I think was highlighted as first in the minds of everyone. How much is it going to cost me, and how that makes me feel about myself, my community, where I am in life, and how we learn to do that and make that a part of the ACA, which is the affordability being a mandate. And I think when we wrote that attribute, we were thinking about the need for that, but I think I'm very aware of what a big shift this is. You certainly don't get off of an airplane and get given the price ticket for how much it was, but that's what happens when you're in the hospital. So we've got a big shift in front of us, and those of us who are on the provider end don't know how to do it. And we've got patients and consumers who feel uncomfortable. So we've got a lot to learn about that. And I think the solution to that will be a multidisciplinary one where we really do a lot of listening and thinking and good research to highlight some of what Cindy said. Number two, related to building meaningful relationships with those who communicate in journalism, the media, social media, and finding meaningful links for the field of health literacy into that. I think we share common interests, but we need meaningful and actionable bridges between those disciplines. And the third one really follows up on the comments that George made that gave me some new thoughts about health literacy and ethics. There are a couple pieces that have been written about it, but I think Beyond Numbers and Beyond Numbers really highlights the opportunities for ethical engagement in public health. And so I see that as another opportunity.
I think, enjoyed the task of separating numeracy from literacy, and taking the day to really sort of consider those separately. And I was struck by I think Dr. Ginsburg's presentation early in the morning, where she said that one of the usual ways of talking about this in I think on the across the Atlantic was literacy, numeracy, and language. And so I think conceptually that helps me think about some more of the tasks that we have moving forward, and in particular with the Affordable Care Act and with the healthcare exchanges, and as Wilma has said, with the navigators and all of the people that we're going to need to put in this infrastructure to help all of these new consumers find health insurance. The thing that I'm ruminating on is about how, most of these, or not most, but a good portion of these new healthcare consumers and healthcare shoppers are from the traditional disadvantaged groups of racial, ethnic minorities, people who don't speak English, people who are at low socioeconomic levels, and so there are a lot of intersections here that I think in many ways sort of magnify the task even more. And so it's something that I'm sort of ruminating on and figuring out how we need to think about that consciously moving forward, because I'm thinking about the guidance that we've put out and the sort of resources that we're putting out to get people enrolled October 1 and beyond. And I feel like we've just, or it's become apparent to me, something that we're just glossing over. Thanks.
George?
Yeah, I
Since you weren't here most of the day, you can just
yeah, I
make it
wasn't
up.
here most of the day, but I've got a couple
Take it
of
up, yeah.
observations nonetheless. One, I really appreciated Darren's comment earlier about this feedback about what the number means, about the risk number. Actually, I think this conversation, both in reading the material and the part of the day that I've been here, really is very tangible to me in terms of bringing this whole topic alive in a way that hasn't over the number of years I've been associated with it. And it takes me back to the joint meeting we had in California with the Quality Forum, and I believe it was also the Health Literacy or the Disparities Group at that point. And remember struggling in terms of trying to think about the 2004 report and how it was really a two-sided issue between the complexity on the one hand and, of course, the capabilities, skills of patients and the population. And I think this, when I think about it as from my background now, clinical medicine and particularly in quality improvement, looking at the magnitude of the problem as laid out in terms of the health numeracy statistics and the distribution in the population, and how and the key issues from buying to preventive care to chronic disease management, to tasks as ubiquitous as taking medications, and realizing the fraction, the large, substantial fraction, millions of people that are having problems with that. And then just thinking about what needs to be done to make real progress of that in the short term. It's not going to happen by educating people in the short term. That's not to say that we shouldn't be doing that, because it's really critically important, both in long term in terms of addressing education in the country, and short term in terms of educating our patient. But it's not going to solve the problem in 10, 20, or 30 years, given the magnitude of the problem. And so I think, for me, this conversation has really focused the emphasis on figuring out decision architectures for common decisions, buying, which I think we've worked on here in the last couple of months with Ruth, with you and your team at Emory, and the commentaries that have been released on that, really important, and some of the stuff that I know was discussed earlier in the day before I got here. But I also think, in terms of picking out some clinical examples around decision-making for prevention, and that issue of what's the role of the professional, how do the flags, you should be raising it when the number is 9 or 10. But then what happens? I mean, do you just jam it down the throat of everybody you see in the exam room? That's wrong. Then what happens, and professionals, individual professionals need a lot of help to figure that out. And that's process engineering. That's skill sets that we don't typically have represented here. And I think the simplification of the interface with the patient needs a lot more attention from us. That's what I'm taking away from this afternoon. In fact, that we have so many compelling examples of decision-making in contemporary American medicine, which is so frequently and so in high volume wrong from the standpoint of overuse and misuse, in which professionals are, quite frankly, often silently complicit. So that raises the ethical issue, and I think there's a significant, but then there should be, if you're trying to figure out the roles, the proper role that people should play in the transaction, the patient, the professional, and so forth. I think we ought to spend a little more attention on that. So that's my comment.
Well, I too thought it was a terrific day, and I remember this idea first emerged that we could have a whole day on numeracy. I just thought this would really help us understand what's happening out there among people who are really trying to use the precision of numbers to describe and to help people make decisions. So I was just totally gratified by the session today. But also what emerged in my own mind is the paradox of precision, in that when we get at the use of numbers, I think it really reveals the inherent complexity of making decisions. And so I don't think we can be satisfied with just trying to reduce complexity. It's got to be to embrace complexity in some fashion, and that complexity is always introduced when you have conversations. And so I'm back to my old song, which is I really think that interaction, that what can that interaction look like? Those interactions look like? How can they be designed in ways that help people make decisions? Is one of the directions this points me toward. And in fact, I would, on the ethical point, I would say maybe we could think about the ethics of not allowing the patient to have a conversation with the provider. What are the ethics of giving someone information and not giving them an opportunity to talk back with us about their meaning and their plans and their own values? What are the ethics of that?
Lionel, let me, okay, that's what I was going to ask. Okay.
I can be brief. One of the things I do want to say is it's been, I think, 2 years since I've actually been to one of these meetings. We've tried to send chief dental officers and we've sent medical directors from our Medicaid plans. So I'm frankly overwhelmed. I did watched the first half on the webinar this morning on the train down from Connecticut, and the second half I was here. Just a couple of comments, and some of mine were both just understanding and listening to what I heard today, and also just conversations around it. The journalism one that a couple of you commented on, one of the things I just have to say, I'm a VP of communications at Aetna. I run the communications organization at Aetna. I talk to reporters every day looking for information on what to write about the Affordable Care Act. I mean, it feels like there is kind of a need on both sides, and there's an opportunity to do something about that. And I think there's a lot of people here who do that, but I think that's a significant opportunity for this organization and this team. A couple of things I noted in two different presentations, two triangles. One that had the doctor and the patient and information, another one that had a doctor and patient and pharmacist. And I don't know if that's a square or if that's two different triangles, but I thought, it's a really interesting paradigm. We've done a lot at Aetna to try to get at building relationships with the clinical community. And it feels like to me, these are opportunities where health plans and the clinical community are actually on the same side. I believe that these are two of the most complicated subjects that there is, healthcare and health insurance, and you layer them on top of each other and they become, frankly, impenetrable. So there's lots of opportunity, and I'm not discounting dental, to be very clear. So I think the opportunities are significant. What I see is, a need to get at what are some of the actionable things, and I know that that's what this group is about. But there was a lot of questions today to try to get at, well, what is the example? And the answers were always, well, the data says this, and the data says that, and the data says this, but the data doesn't point at anything with clarity. So how we work together to help on that, I think, is huge. And then just one other opportunity on the choosing health plan stuff. I think as we get to opportunities where we get more uniform around what are the measures that we're using to choose health plans, to define quality. I think to some of the points that Cindy made, using other standards is a good step, but I think that less as an insurer, but more as a consumer, what are the measures that we're asking? What do we think is important? What does the research tell us that consumers are really looking for? But then how do we get to a handful of measures? Not necessarily, the checkbook I think is phenomenal, but not just 1 to 5, but maybe only 1 to 5 organizations that do that sort of stuff, as opposed to myriad ways and myriad organizations. So I think you still end up with confusion for consumers.
I have a couple of interesting points to bring up, and the first one is actually relating back to one of our speakers in the April workshop. If you remember Bridget McCandless, she was the founding member and the medical director of the Shared Free Clinic, and it reminds me of her conversation and the importance today that we're hearing about context and knowing your audience. And if you remember, she talked about, so often as clinicians, we talk about risk in terms of a 20 or 30-year horizon, and talking about, for example, managing your diabetes. And if you want to prevent complications like losing your eyesight or losing a toe, you want to take the following actions. And she said in her population, low income, no insurance, 20 or 30 years, that 20 or 30-year horizon means nothing. 2-week horizon, because within 2 weeks, you get a paycheck and your rent is due. So that's the time frame that risk is communicated to that population. She said they don't care about losing eyesight or losing a toe. They care about erections and infections. And so she communicates risk to that audience in a language that's meaningful to them. And I thought that was so important, and I think worth revisiting in this context. The other thing from a pharmaceutical perspective, in which the industry that I represent, I'm thinking a lot about how we talk about numeracy is measured in healthy individuals, and yet when you're sick or stressed or overwhelmed or under time pressure, all bets are off. And I apply that to the clinical trial experience, where it's very controlled, and you're not under stress, and your experience with a medication regime or adjusting your insulin dose or using a device is very controlled. And then we flip to post-launch in the marketplace and we're looking at real-world evidence and it doesn't match the evidence in the controlled environment, and how much of that is because we've, the effect on your ability to utilize numbers and make decisions and calculate risk because you're in a stressed situation. So that certainly has real world application that I'll take back to my organization. And then the third thing I want to pose to the group, and perhaps this is a future workshop topic, but in our efforts to understand and deconstruct the task of giving medications and self-management of medication regimes, the struggle that we have as a pharmaceutical industry certainly is the need to want to represent risk clearly and in plain language, but we're held to the regulatory environment placed on us by the FDA. And so how can we come together and kind of find the middle ground? We need help with that. And this certainly brought to light the importance of how to accurately communicate risk in this highly regulatory environment that we're in, yet patients are going to need this information more than ever and written in plain language. So that's a struggle we'll have to figure out, and perhaps this is a forum to do that.
Thank you. So I as well enjoyed the day and could build on many of the things that you've already brought up. And so what I'll just say is that, numeracy is yet another level of complexity that health is, right? Health and healthcare, and it's a very personal thing to everyone. And I think that our group, because we represent people that touch the consumer who deal with all these issues in many ways, that the consumer is expecting someone or all of us to come together to try to help simplify and try to help them navigate, this world of health. And so that's what I would challenge us to do, is look for more opportunities to partner and to also have the consumer here at these tables to be able to help influence us on where we need to go.
Briefly, I really got struck by the importance of numeracy and patient education, and especially the concept of always consider the consequence of data type with patients with specific and immediate needs, kind of what was referred to earlier in Lori's comments. And also, I was struck by George's discussion of ethical considerations associated with information versus persuasive presentation of data. I think there's some really deep issues there when you think about it, and how you convey risk to patients. I'm also realizing too that I think numeracy is one of our greatest health literacy challenges, and to invest in the future, we need to focus on cross-curricular opportunities in math, biology, health, consumer and health education, and PE. We don't do that anymore. I remember, well, I won't go there. But anyways, in closing, and then Lindsay was talking about the KISS method. Were you talking about keeping it statistically simple? I think so. That's all I have. Thank you.
Yeah.
My conclusions, one, I think this was an incredibly successful day. And for me, it really reinforced and reified the importance of numeracy as a central issue, perhaps now in health literacy. And it's very, very important to decision making. And I think that we can never now separate out those two. Just a central piece in that. And the examples that were given throughout the day really brought that home to me in a magnificent way. So I was very excited by that. And I feel that that's a real push to action. I think the second takeaway is a reminder of the importance of rigor and scholarship in our work. The most successful examples that were given were examples that were well piloted and rigorously examined. And I think that we have to remember that over and over again, the importance of pilot testing. We call it sometimes consumer testing, and building on that. So some of those examples were just supreme and a reminder of the importance of rigor. And part of that importance of rigor is indeed the mandate that as we move forward and address numeracy in health literacy, we have to partner with experts in numeracy. We have to turn to the experts and bring them in full partnership and not have the audacity to go off on our own and think we're measuring this or changing this in appropriate ways. We really have to. I want to be sitting down at the table with Linda. I want to be informed about that. And I think rigor demands that kind of partnership. And I think the third thing that I want to bring up ties in a couple of issues. One, a mention of ethics and ethical dilemmas, and Darren's sort of call and plea, which I agreed with, I'll put in slightly different language. Do we have to continue doing this dance over and over again because people are doing things poorly? We have known since 1993, with the publication of the first adult literacy survey in this country, about the skills of U.S. adults. We have it well documented. Over 26,000 adults were the N for this. We've known this. We've known about the quantitative skills. And it's no longer an ethical dilemma. It's an ethical imperative that we pay attention to this and we call it like it is. That it is unethical to continue to produce these huge demands on people when we know that it's inappropriate. I think it's a legal issue. I think it's an ethical issue. And I think we need to make more of that as we go along and say, you know, to someone like Darren, you're right, and we have to stop doing this dance. We really have to get in regulations and rules and requirements.
I think 3 brief take-home points. Numbers are common, perhaps ubiquitous, and we have problems with numbers, all of us. I think that the answer we most got was reduce complexity, which is the same answer we got in every other meeting. And I think that we learned some new tools specifically related to numbers, but I think it's, you know, it does fit into this general notion of how do we reduce the demands and reduce complexity. I modified my statement on that after Linda spoke, because I started thinking, well, I really do think we have to reduce complexity, but we have to allow that there's complexity outside of the facts or the numbers that we have to deal with in the conversation. I think you made a nice point there. And lastly, I thought that Brian made an important point to remind us all that we have to remember the task when we design anything. And oftentimes we design things because we think they're important, but we're not thinking of the task that someone has to apply. And I thought that was just a really important point that he made.
What's the end point in providing health empirical data to people? What's the ultimate goal? Essentially, that's what I'm left thinking about as I take the metro home this evening. We created, over the last 7 or 8 years, a huge data set. For the first time ever, you can now see the summaries of clinical trials in a standardized format. And it's now fairly well populated. It's never happened before, and it was a massive effort just to create that, okay? Now, the issue from today is that the wisest investment that we could make as a federal agency, and the wisest thing that I can do to think about that, is to not be terribly complacent with its creation, and to think instead about how do we help people derive meaning from that huge amount of information. And secondly, how do we, once they derive some meaning from it, can we possibly use that as a resource to help people make better healthcare decisions? It seems to me that our interest and focus is how to do that across population spectrums and how to help professionals do that as well. How to help healthcare providers use that resource is just as important and different a topic as helping journalists use it. I work with journalists all the time on how to use it. But helping public health practitioners, a different task all by itself. But nevertheless, one of the things that I think we need to do.
I know I'm standing between us and our taxis, so I'll be brief. So I've been a numeracy groupie for a long time, and I've always felt that numeracy was the critical issue, or a major, really critical issue in health literacy. So I want to compliment the planners and all the speakers. I actually think this was a fabulous session. My brain has been tingling all day long. So take home. Number one, numeracy is unbelievably low, or I don't know if it's unbelievably low, but it's pretty low in our entire population. And I think one important point came out, even if you're measured as proficient, you probably still have problems with numeracy issues in the right time, in the right place, and the right level. So it's pervasive. It's not really separate from health literacy. I think, I believe Rima's one that said, there are a lot of words that have implied numeracy issues in them as well. So one take home for me is training or educating our healthcare providers. I think you mentioned already, but I'm thinking, of course, of medical students and residents that I work with. And I know they have a lot. Doctors actually are not very numeracy proficient. Somehow going to medical school doesn't really make you mathematically talented. It's actually some other part of your brain, I find. So doctors often have a lot of difficulty actually understanding complex. So I think we have to do something about that. I think another lesson, I think, was the real powerful lessons from Rob's Consumer Checkbook and Lynn Quincy's Consumer Union about going to the user and understanding what they need to know and want to know to make decisions, and how can we, in an iterative way, interact with them about that. And I know actually from my own work in developing things, it's through our continuously pilot testing things and being surprised that what we thought people needed or understood was not at all the case, that we learned that. And finally, I do think that this has been touched on, the need really to pre-digest information, to make it meaningful by categorizing it and making it evaluative, to limit it, at the same time to recognize somehow that there's a complexity that may need to be addressed, I think is a theme that's come out. And I would say that I'm on the side of limiting it, but I think I like the idea of this tiered level, so that you start with, with a simpler or more limited set, but you allow people to be able to drill down and get more and more complex as they want to, but they're not required in order to make decisions.
Just a couple additional comments. One is, we're talking about providing information. And one of the things I think that, and talked about the trust that people have in their own physicians. So there was some actually debate, you might say, about to what extent is this information provided to the patient directly, to what extent is it related to their relationship with their physician. And it seems to me that one rule tends to be, in my mind, that transparency adds to trust, or perhaps it's the opposite, that secrecy adds to mistrust. And that's true in many different kinds of things in society. And so one of the things that I think, to follow up on your point about the tiering, is that many times simply having the information available that somebody can get to it adds to trust to whatever the higher tier is that you're presenting to people and whoever is presenting it. The other thing is, and I remember having the same thought about previous workshops when we were talking about the literacy in terms of verbal literacy. And that was, we are actually kind of on the bleeding edge of addressing something which is actually a problem for our society. And that is that many things in society are becoming more complex. Many things in society require numeracy, whether you're working in a factory or, frankly, if you're making change at McDonald's and the current goes out. And so we're kind of at the bleeding edge of that because of the complexity of healthcare and because of how much and how dangerous it can be as it affects each of us in our health. But that means two things. One is we may be able to learn even more from what others are doing outside of healthcare in the area of numeracy. And the other is, I would hope that we learn things that we can share with others that help them address this larger societal problem. This has been a great day also, I thought, both with the presentations and frankly from both the comments and the questions that you have all have asked. So I think it gives us, I've certainly learned a lot, and I think it gives us a lot to kind of think about and digest to figure out what we might do next, given what we've now learned. I will now say that that will conclude this workshop. So I assume I'll see most of you tomorrow at the Roundtable, if not all of you. And I wish you all a safe and cool trip to wherever you're going this evening.
And
Thanks.
just a reminder, we have our Roundtable member working dinner tonight. It's on the agenda. It's 633 D Street, so it's within walking distance. Indian food, so we're experimenting again. So that starts at 6:30. So it's 633 D Street. If you go out the front door, you turn right and you go to the corner, that's E Street. You go one more block down, that's D Street. You turn right again, you'll hit 6th Street, and about half block down, you'll find Resiga.
So now we need to worry about geographic.
Yes.
Structurally challenged.